front. Last row here, please, this side. All right, so we will continue our discussion of the topic on management of pharmacotherapy of epilepsies. So, ground rules remain the same. Please don't make me call you out. We start with what we had covered in lecture 1. All right, a quick revision. Okay, आप बताएंगे what is the difference between a seizure and epilepsy? Okay, and what is epilepsy? When do we call it an epilepsy?
Recurrent episodes of seizures.
What is the minimum criteria for diagnosing epilepsy? How many seizures should have happened? At least two episodes of seizures. Okay. All right, here. Tell me what could be the possible causes of a person having seizures or epilepsy? Brain injury, okay. Infections, systemic infections as well as infections of the CNS. Next. Bato, sit. Yes. That's the molecular mechanism. What are the etiological factors or causes? Next. CNS inflammation could be in the form of autoimmune or infective cause. So there could be autoimmune encephalitis or encephalitis due to infections. Okay, what else? Injury during childbirth, maternal injuries, metabolic disturbances including electrolyte disturbances. There could be unknown or what we call as cryptogenic epilepsy. Okay, please sit. Okay, so what is the difference? Madam, aap bataएं. What is the difference between focal and generalized seizures? These are the two main varieties of seizures, focal and generalized. So what is the main difference between them? Okay. So generalized seizures are always with loss of consciousness or awareness. Focal could be with or without. Okay. Next, any other difference? These are varieties. What is the difference? These are types of generalized and focal seizures. We will come to that also. How much of the brain is involved in focal seizures and in generalized seizures? What does the word focal mean to you? Focus, focal, it's localized, it's in a single part of the brain. Generalized is the seizure activity is all over the brain. Okay, next. Can you tell me what are the different types of generalized seizures? Generalized tonic-clonic seizures, what we call as GTCS or grand mal epilepsy. Okay, what else? Clonic seizures, tonic, atonic, absent seizures. Okay, sit. What do you mean by absent seizures?
The patient stares into the space blankly and he's not
So there is a very temporary cessation of whatever activity the patient is doing. Generally it's a child, right? There's a blank stare and gaze. So that is your absent seizures. Okay, here, this side. When we talk about anti-seizure medications, right, we need to understand what is their mechanism of action. So for that we need to be aware of what are the basic mechanisms through which seizures are caused. What could be those mechanisms? Increased excitation, absolutely correct. So what is involved in increased excitation? Glutamate. Okay, what else? Sticking to excitation, is only glutamate involved in causing excitation, or it could be due to some channels also? Over excitation of sodium channels or over activity of sodium channels. And which type of calcium channels are important? T-type calcium channels. Okay. Next, what is the other pathway through which seizures could be produced other than excitation? Decreased inhibitory pathway. So what is the main molecule involved there? GABA. Could there be any channels also involved in inhibition? Chloride channels. What else? There could also be hyperpolarization due to potassium channels. Right. Okay. Sit. So let's start with lecture 2, that is today's class. So we will again have a look at the drugs whose names I had introduced in the previous class. We will look at them based on their mechanism of action. So we will cover profiles of individual drugs. So some of the most important drugs belong to the classical or the older, or what we can now call as the first generation of anti-epileptic drugs or anti-seizure medication. So that's another term which is standard. ASM stands for anti-seizure medication. So these are drugs that you cannot forget. You have to remember these names: phenytoin, carbamazepine, valproate or valproic acid, ethosuximide. Then we have already had a very detailed look on benzodiazepines, and we know that one of the uses of benzodiazepines is for as a anticonvulsant or anti-seizure medication. Then we will have a look at a variety of drugs which now belong to so-called second and third generation of anti-epileptic drugs or anti-seizure medication. So this is something that we have just touched upon. Seizure, it's a transient disturbance, can manifest in the form of motor, sensory or autonomic disturbances. Epilepsy, when you have risk of periodic and unpredictable or unprovoked seizures. These are the types of seizures that we just talked about. Focal could be with awareness. In that case, it is called simple partial. When it is without awareness, it is called as complex partial. There could be motor or non-motor manifestations. Generalized seizures, the main types are generalized tonic-clonic seizures, absence seizures, and there is also a very high prevalence of what we call as myoclonic seizures. In fact, there is a syndrome called as juvenile myoclonic epilepsy, which is responsible for 10% of all generalized seizures that we see. Then again here also you can have motor or non-motor. It is likely to be motor when it is GTCS. When there is absence seizure, it is non-motor manifestations. Alright, let's come to the drugs. And buckle up, we are going to have a lot of drugs to discuss. By the way, before that, congratulations to all the cricket fans. The team has reached the final. And more importantly, we will not suffer headache now. That guy is an absolute psychological trauma for all Indians, isn't he? Travis Head? Okay. Alright, so okay, I want to go to the first of the 3 generations of drugs which has gone. Okay, anyways. So let me talk to you about general mechanisms of anti-seizure drugs. So we will try to classify drugs based on clinical use and mechanism. See, what I wanted to put up was, unfortunately the slides did not work. When we classify anti-seizure drugs, or for that matter any other drugs, into generations, what is the basis of it? Basis in general is the timeline in which they are discovered. So if you talk about anti-epileptic drugs, one of the first or important anti-epileptic drugs to be discovered was phenytoin, and this was way back in 1937. So almost 100 years back, maybe 88 years back. Or is it 88? Sorry, my maths is a little off. It should be how many years back? 92 years back. So 1937. Anyways, now after phenytoin, you had a plethora of drugs being discovered which included barbiturates like phenobarbital. Then you had benzodiazepines in the form of diazepam. Then came drugs like carbamazepine, valproic acid. So this was the first generation of drugs which got discovered right up to 1990s. In 1990s, we had a different group of drugs being discovered which did not have any resemblance structurally or functionally with the earlier drugs. The mechanisms of actions were similar, plus there were newer mechanisms of actions. So in 1990s, we discovered another 7-8 important drugs, and these are called as the second generation drugs. So they include drugs like lamotrigine. If you remember, I talked to you about lamotrigine. It is also a broad spectrum drug. Then there were a lot of drugs like tiagabin, GABA acting drugs like gabapentin, pregabalin. All of them were discovered. Then cut to this millennium. From 2000 onwards till now, you have again had a new group of drugs which have been discovered and developed, right? They are in ways improvement over the previous groups, but at the same time, their efficacy is still to be well established. So you have a number of newer drugs like lacosamide, like rufinamide, like stiripentol, and a number of these new drugs have come up from 2000 onwards. So that is how the generation goes. Now, if we look at these drugs, let's have a look at drugs which act on GTCS or generalized tonic-clonic seizures and partial seizures. So you can see the number one mechanism of action could be thought of as those which inhibit the use-dependent sodium channels. So these are your frontline anti-epileptic drugs. You have drugs like phenytoin, carbamazepine, valproate, lamotrigine. These are very important drugs. Then the second main mechanism of action could be those which enhance GABAergic action, either by facilitating the action of GABA, mimicking the action of GABA, or by inhibiting the degradation of GABA, or increasing the synthesis of GABA, or inhibiting the reuptake of GABA. So there are many ways in which GABA action can be increased or enhanced. So you have older drugs, you already know about them, barbiturates and benzodiazepines. Then there is valproate. You will find valproate in practically all mechanisms of actions. Then you have the newer drugs. These are the second generation drugs which have come, which act primarily through GABAergic action. So you have vigabatrin, you have tiagabin. You can see that in their name there is GABA, right? Lamotrigine is like valproate. You will find lamotrigine in sodium channel action also, in GABA action also. Now, what about the third mechanism of action, which is inhibiting glutamatergic transmission? And this is mainly through the receptors for glutamate, which are AMPA receptors, which are kainate receptors, NMDA receptors. So you have now got antagonists on NMDA receptors called felbamate. You have AMPA receptor antagonists like lamotrigine, again is here, topiramate, perampanel, even valproate has some action like this. Then you have specific subtypes of glutamate receptors which have also been targeted. So a drug like rufinamide acts on a receptor called mGlu-R5. Next, you have a new class of drugs which have a very specific action on a protein called the synaptic vesicular protein, SV2A. So this synaptic protein is responsible for the release of glutamate and release of GABA. So by targeting this particular vesicular protein, we can decrease the release of glutamate and we can increase the release of GABA. So there is one drug and a congener of this drug which is available now. So that drug is levetiracetam. There is another drug called brivaracetam. So that is also an analog. Finally, the newest mechanism of action is by inhibition of a protein called CRMP2, which stands for collapsin response mediator protein. This protein is thought to be connected to neurotrophic factors in the brain. So this is an entirely novel mechanism of action, whereby leaving aside your sodium channels, your GABA and your glutamate and all these things, you are now directly targeting neurotropic factors. So the drug which has come out is lacosamide. Okay? So this is a fairly new drug, this is a fairly new drug, these are fairly new drugs. These two groups of drugs are what we call as the core anti-epileptic drugs, or the front line or first line anti-epileptic drugs. Okay? One mechanism is missing here. What is that? T-type calcium channel current. Why is it missing here? Yes, because right now we are talking about drugs used for generalized tonic-clonic seizures. Okay? The T-type calcium current is specifically involved in pathogenesis of absence seizures. So drugs which inhibit that current are specifically useful for absence seizures. Now here itself, you need to remember that among these drugs also there are some drugs which can inhibit that T-type calcium current also. What are those drugs? Valproate, broad spectrum. Lamotrigine, broad spectrum. Topiramate, broad spectrum. Okay? So if you look at sodium and the GABA based action, I had also shown a graphic in the last class. So this is what a sodium channel looks like. So you have an activation gate, you have an inactivation gate. In an open state of the sodium channel, this gate will be open. This is the inactivated state where this gate is closed. Now all of these drugs, your phenytoin, carbamazepine, valproate, lamotrigine, they are prolonging this state of inactivation. They are not allowing the sodium channel to go back to which state? From inactivation it has to go to which state? Resting state, in order to be available again for activation. So all of these drugs are prolonging the inactivated state of the sodium channel. So they are preventing the repeated activation of the sodium channels, thereby preventing the repetitive firing of the neurons, which is thought to be the core mechanism behind excitation leading to seizures. Okay? So most of the frontline drugs, as I mentioned, phenytoin, carbamazepine, valproate, lamotrigine, they all act through this sodium channel, so prolonging the inactivated state. So there is a preferential blockade of those sodium channels which are voltage gated, which open due to repetitive firing. The blockade is also use dependent. So the higher the use, which means higher the excitation, the more these drugs will be able to block those sodium channels. Lastly, their core action is prolonging the duration of the inactivated phase, thereby preventing these channels to go back to the resting phase, thereby not allowing them to get activated again. So that is the core mechanism of action. Now what about GABA? So this is another diagram which I had shown in the last class. So here also you can see that at GABA sites, multiple mechanisms can be there. You will have drugs like benzodiazepines and barbiturates, also drugs like felbamate, topiramate, which can directly act on GABA based receptors, the chloride channel complex receptors. Then there could be drugs which inhibit the degradation of GABA, so there are different types of enzymes involved, so they can inhibit those enzymes. There is also a drug which can inhibit the reuptake of GABA back into the neuron. So on the GABA receptor, you have barbiturates which increase duration of opening of chloride channel. You have benzodiazepines which increase frequency of opening of chloride channels. Then you have GABA transaminase and succinic semialdehyde dehydrogenase inhibitors. So these are vigabatrin and valproate. Then there is tiagamin, which inhibits the reuptake through the GABA uptake transporter, simply called as GAT. Then there is also stimulation of an enzyme called glutamic acid decarboxylase, or GAD enzyme, which increases the synthesis of GABA. So here also valproate is there. So these are two very important mechanisms, sodium channel and GABA, based on these two targets. Now what about drugs used for absence seizures, also called as petit mal epilepsy? So here the core target is T-type calcium channels, which are responsible for carrying the thalamocortical current in our brain, which in turn is responsible for the characteristic EEG features of absence seizures. So by blocking these T-type calcium channels, you will be able to control absence seizures. So they are low threshold calcium currents carried by these channels, and they are responsible for the typical 3 Hz and spike waves seen in absence seizures. So these are the drugs, and they are definitely the drug of choice for absence seizures. So you have 2 very important drugs to remember for absence seizures. One is a pure absence seizure drug called ethosuximide. It is used only for absence seizures. Okay? And then there is valproate, which is the broad spectrum drug. Here it is mentioned that ethosuximide is the drug of choice for less than 2 years of age. Some books also mention less than 5 years of age. And valproate is the drug of choice for more than 2 years or more than 5 years of age. There is a reason behind that. Valproate is actually as effective as ethosuximide. It has a more proven track record. But the problem with valproate is if it is given in children, specifically those less than 2 years of age, again less than 5 years of age, there is a rare chance of suffering fulminant hepatitis. Fulminant hepatitis, so that's a serious adverse event that can occur in very young children. So that is why valproate is not given for absence seizure in very young children. So there we can use ethosuximide. Okay. Now this blockade of calcium channels could also be on N-type calcium channels. So L-type we have CCBs, calcium channel blockers, the core CCBs. Then you have T-type blockers like ethosuximide, valproate. Then there are also some drugs which are blockers of N-type calcium channels. So this N-type calcium channel has now been linked with release of glutamate. So some of the drugs which act on these N-type calcium channels are also now known to inhibit the release of glutamate. So these drugs are lamotrigine, gabapentin, pregabalin. These drugs which are supposed to be working through GABA, they also have some additional action through N-type calcium channels, thereby releasing glutamate. So one thing to just tell you, whatever we know till now regarding mechanism of action of anti-seizure medications or anti-epileptic drugs is still evolving. Especially for the newer drugs which have come in the last 10-20 years, we are still trying to find out, still trying to understand their exact mechanism of action, right? So that is to be kept in mind. Now let's have a look at individual drugs. Now these individual drugs are important from the point of view of not only understanding their mechanism of action, but also their adverse effect profile. This is a very common question that is asked. Like one of the first drugs that we will take up is phenytoin. One of the commonest questions that is asked based on phenytoin is the adverse effect profile of phenytoin, right? So let's have a look at phenytoin. So it belongs to a class called hydantoin. Phenytoin, it comes as a salt, phenytoin sodium, sometimes it comes as a non-salt preparation also. So there is always an issue that if you use phenytoin formulations of different manufacturers, there is likelihood that there may be variability in bioavailability, thereby causing variations in blood levels. So one important thing to remember when treating a patient with phenytoin is try to stick to the same brand of medication, same formulation. If you change formulations, you have to monitor the patient because this drug does not have a broad therapeutic index. It has a narrow therapeutic index, it has a narrow safety margin. So that is why any changes in blood levels can take the patient into toxicity. Okay? So with that in mind, the mechanism of action for phenytoin is purely based out of sodium channels. So it causes blockade of the use-dependent sodium channels at higher concentrations, and these are 5 to 10 times higher concentrations. These concentrations are not used in therapeutic usage. So they may also inhibit calcium reflux and neurotransmitter release. But the core mechanism is blockade of sodium channels. This is the chemical structure of phenytoin. Primary use right now, phenytoin is a co-drug of choice for what we call as focal seizures with impaired awareness, also called as complex partial seizures. Sometimes because of the manifestations, they are also called as psychomotor seizures. Okay? So this is specifically useful for focal seizures with impaired awareness. It can also be used for simple partial, which means focal seizures with preserved awareness, as well as generalized tonic-clonic seizures, and it does find important use in status epilepticus. So just to tell you at this point itself, we talked about status epilepticus in the last class. The first two drugs to be used for status epilepticus are benzodiazepines and then phenytoin. And there is actually a newer formulation of phenytoin called as phos-phenytoin, which is a phosphorylated version of phenytoin, because that is more suitable for intravenous use, which we require in status epilepticus. Okay? And these are the adverse effects. So there is a mnemonic, you will find these mnemonics in many books. So a lot of the adverse effects, the important adverse effects of phenytoin start with H. Okay? So you can see here hypertrophy of gum or hyperplasia of gums, that is very common. 20 to 30% of people who use phenytoin, they have hypertrophied gums. Okay? It can be prevented by maintaining good oral hygiene. So that is one of the most important things. Then hirsutism, particularly in females, is very troublesome. Hyperglycemia, Hydantoin syndrome, it is a, what kind of a syndrome do you think this is? This is a teratogenic effect. So if phenytoin is given to pregnant females, it can cause Hydantoin syndrome in the fetus. We will see what happens in Hydantoin syndrome. Then hypersensitivity reactions and also hypertrophy of the lymph nodes. So hematological reactions are also possible. So these are important adverse effects of phenytoin. Okay? What else? So this is the, as I mentioned, oldest non-sedative anti-epileptic. It is effective against all seizures, not against absent seizures. There is a defined therapeutic plasma level. The usual dose is around 300 milligrams per day. Other than epilepsy, phenytoin also has uses in conditions like trigeminal and related other neuralgias, digitalis induced arrhythmias, and it has been found to have some wound healing properties. It's not commonly used for any of these conditions. Trigeminal neuralgia is actually a common problem, relatively common problem. Phenytoin is one of the treatment options available for trigeminal neuralgia. But another anti-epileptic drug is actually more commonly used for trigeminal neuralgia, and that is, any idea? Carbamazepine. Okay. Pharmacokinetics, this I have already mentioned to you. Because of differing or variable bioavailability between formulations, you avoid switching between brands. Tablets of phenytoin are available for extended release as well as rapid release preparations. There is no intravenous or intramuscular use possible for phenytoin. So to facilitate parenteral use of phenytoin, a new formulation called phos-phenytoin has come into the market. It has a high plasma protein binding, more than 90%. Important thing to remember, phenytoin and some of the other anti-epileptic drugs are enzyme inducers. So you can clearly remember this now here itself. Phenytoin and carbamazepine, two of the frontline anti-epileptic drugs, are enzyme inducers. They are enzyme inducers. Whereas valproate, which is another major anti-epileptic drug, is an enzyme inhibitor. So when I am saying enzyme inducer, which enzyme am I talking about? I am talking about the cytochrome P450 enzyme, right? CYP enzyme. So because of this enzyme induction, you are likely to see drug interaction. So two very important drug interactions which are seen with phenytoin and also with carbamazepine are linked with warfarin. Warfarin is an anticoagulant. So if warfarin therapy is going on and you start phenytoin or carbamazepine, there will be enzyme induction, there will be increased metabolism of warfarin, you will lose the effectiveness of warfarin. Similarly, same problem is seen in females consuming oral contraceptive pills. There also, these drugs can induce faster metabolism of the OCPs, thereby causing contraceptive failure. So these are important interactions to remember. Phenytoin is a drug which follows mixed order kinetics, also known as pseudo zero order kinetics, also known as Michaelis-Menten kinetics. What is it? What is mixed order kinetics? Any idea? There are only two orders. first order and zero order. So these drugs like phenytoin, they follow both first order and zero order kinetics. Why would that be? At lower doses or therapeutic doses, they follow first order kinetics, which is generally most drugs follow. What most drugs follow. When the doses go beyond the threshold, the plasma levels go beyond the threshold, the metabolic pathways are saturated, and then it goes from first order to zero order. I am saying all of this assuming that you know what is first order and zero order. Do you know? You know, all of you know what is first order and zero order kinetics? Then anybody can tell me what is the basic difference between first order kinetics and zero order kinetics? It is such a basic pharmacology question. Come on.
So in first order, the percentage of the concentrations is keeping in the time, and in zero order, make a fixed amount is keeping.
Yes, he is pretty much right. Essentially, in first order kinetics, you have a constant fraction of drug which is excreted or metabolized and excreted. In zero order kinetics, there is a constant amount of drug which is metabolized and excreted. Okay? So these drugs like phenytoin, there are some other drugs also, they start with first order kinetics. If the doses go higher, they switch into zero order kinetics. Okay? So TDM is recommended. Any idea what is TDM? Therapeutic drug monitoring. It means you should measure the plasma blood levels or plasma drug levels and see whether they are within the therapeutic range or not, and accordingly adjust therapy or continue the same dosage. All right? What happens if there is overdose of phenytoin? So now we are going into the toxic effects and adverse effects of phenytoin. So if there is an overdose, you will firstly see symptoms which indicate cerebellar vestibular disturbances. So you have problems like diplopia, ataxia, and nystagmus. ये जो तीन symptoms हैं, these three symptoms, please remember them. You will see that a lot of anti-epileptic drugs have the same constellation of adverse effects. Diplopia, ataxia, nystagmus, because they tend to affect the cerebellar function. Then there are features of depression of the CNS, which manifests as drowsiness and lethargy, another common feature of many anti-epileptic drugs. Patient feeling sleepy, drowsy, right? The effect that all the lectures have on you, those things are there. Then gastrointestinal effects, GI effects in the form of nausea, vomiting, diarrhea. So these are the overdose features of phenytoin. Lastly, particularly with the parenteral preparation of phosphenitoin, there are now known cases of cardiac arrhythmias. So that is a specific problem with parenteral administration of phosphenitoin. Okay? Chronic toxicity, we have already looked at the adverse effects beginning with H. All right. Next we go to the teratogenic effect of phenytoin. So one thing becomes clear, phenytoin should not be given in pregnancy. It is contraindicated in pregnancy. It's not safe for use in pregnancy because it can cause a teratogenic syndrome called as fetal Hydantoin syndrome. Hydantoin syndrome, why Hydantoin? Because phenytoin ka jo structural class hai, that is Hydantoin. Okay. So what happens in this? First is growth retardation. So there may be IUGR, uterine growth retardation. Then mid-facial hypoplasia, cleft lip. These are two important features of fetal Hydantoin syndrome. Anomalies of the limb, hypoplasia of distal phalanges and small nails. Okay, in the hands, there are defects which happen. Can you recall another drug which is known to cause limb defects if taken during pregnancy? Yes? Thalidomide. Thalidomide, what does it cause? Seal limb deformity. Seal limb deformity. The limbs, particularly upper limbs and even the lower limbs, they are not formed or not well formed. Okay. Heart defects are also common. So that's fetal Hydantoin syndrome. Drug interactions, I have already mentioned this. So because of its nature of inducing cytochrome P450 enzymes, particularly CYP3A4 and CYP2C family of enzymes, you can have multiple drug interactions with phenytoin. So it can induce metabolism of important drugs like oral contraceptive pills, steroids, rifampicin. So tuberculosis में therapy failure हो सकता है, doxycycline, levodopa, vitamins like K and D. So there might be deficiency of vitamin K and D in individuals. Then drugs which are CYP enzyme inhibitors can decrease the metabolism of phenytoin, causing toxicity, because phenytoin खुद भी metabolize होता है by the same CYP enzymes, the CYP2C9 and CYP2C19 enzymes. Now this is one very important thing to understand, that the important or first line anti-epileptic drugs, they all interact among themselves. So phenytoin interacts with carbamazepine and phenobarbital. Both can induce phenytoin's metabolism and phenytoin can induce their metabolism. So what does this implicate? When you are treating a patient of epilepsy or someone having recurrent seizures, there is no point in giving these drugs together. So they are used as monotherapy generally, and that is actually one of the principles of treatment of epilepsy, that you rarely use multiple drugs. You use one drug, you see that that drug is not effective, you substitute that drug, you change and start another drug. It's only recently when the second generation drugs have come that some adjunct add-on use is now possible. Otherwise, among the first line drugs, you generally do not combine. You are not giving phenytoin with carbamazepine, or you are not giving phenytoin with valproate, you are not giving carbamazepine with valproate, or even combining benzodiazepines or barbiturates with these drugs. Okay, so they are generally used single drugs, as single drugs. Okay, valproate has an inhibitory effect on metabolism. Okay, so every major anti-epileptic drug interacts with the other drug, and the same actually holds true for the earlier second generation drugs like lamotrigine also. The same kind of interactions happen here. Okay, next we go on to carbamazepine. So the chemical structural class is immunostilbene. Carbamazepine, it comes as tablets, generally 200 milligram tablets. And what's its mechanism of action? Again, very similar to phenytoin, acts through blockade of use dependent sodium channels. Alright, so this will slow the rate of recovery from the inactivated state of the sodium channel. This is the chemical structure. Primary use of carbamazepine, it's a co-drug of choice for all types of focal seizures and also for generalized tonic-clonic seizure. So this is a fairly commonly used drug, carbamazepine. Can be considered drug of choice for both focal seizures and for generalized seizures. But which type of generalized seizures? Tonic-clonic seizures, not for absence seizers, because it does not have any effect on which channels? T-type calcium channels. There is no effect of carbamazepine or phenytoin on T-type calcium channels. Okay. Main adverse effects, it does not have a very characteristic toxicity profile like phenytoin, but there are some important adverse effects. It shows dose-dependent CNS depressant effects, problems like drowsiness, dizziness, headache, blurred vision, slurred speech, ataxia, vertigo, diplopia, and it can also cause allergic reactions. So mainly the adverse effects are related to CNS depression for carbamazepine. Okay. So as I mentioned, partial seizures or focal seizers as well as generalized tonic-clonic seizure, you can use it as a first line drug, first choice drug. Its pharmacokinetics, there is an erratic slow absorption after oral administration. The plasma protein binding is much lesser compared to phenytoin, where it was more than 90%. So you don't see any drug displacement reactions. Half-life is generally on the higher side. Metabolism is through CYP3A4, and more importantly, like phenytoin, it is also a potent enzyme inducer. So by inducing the CYP3A4 enzyme, it can actually induce its own metabolism. It can also induce metabolism of valproate, of some of the newer anticonvulsants like lamotrigine, topiramate. Now tell me, what will this property lead to Carbamazepine inducing the enzyme which metabolizes itself. You are giving the drug and that drug is also inducing the enzyme which is metabolizing it. What will you see? It will lead to some degree of tolerance. The dose that you give continuously, you will not get the same response with that dose. So you may have to increase the doses as the therapy is continued on carbamazepine. So that's the important. So this is called as auto-induction. Okay. Then there is also, this is the usual dose. One of the issues with carbamazepine which people feel is that it needs to be given how many times in a day? 3 times in a day. And for epilepsy, the therapy is not like you give therapy for 1 week, 2 weeks, 1 month, 2 months. Once a person is diagnosed with epilepsy, the minimum duration that is recommended for treatment is 2 years. So imagine a person having to take 3 tablets every day for 3 years. So compliance is likely to be an issue. Medication adherence is likely to be an important issue. Okay. Adverse effects, I have already told you. One of the things that can happen with overdose or acute intoxication is that the patient may go into stupor, coma, and the drug itself can cause convulsions. It's an anticonvulsant, but in overdose it can also precipitate convulsions. Other than that, there is also respiratory depression. On chronic therapy, I have already mentioned the CNS effects. These are dose dependent. There are also allergic reactions, hypersensitivity reactions like rash, commonest manifestation, but in rare cases there may be more serious manifestations, hypersensitivity. So there could be SJS. What is SJS? Stevens-Johnson syndrome. And there could also be TEN. What is that? Toxic epidermal necrolysis. These are serious manifestations of hypersensitivity. There could be hematological abnormalities like leukopenia, blood count, the white blood cell count going down. There could also be aplastic anemia. These are rare adverse effects, but they can happen. Sometimes leukopenia may be transiently seen at the beginning of therapy when the patient is administered carbamazepine, and then it disappears. In some rare group of patients, it may persist. It does not cause any problem, but there may be a persistently low white blood cell count. Okay. Another issue which is not clinically troublesome but seen rather commonly is hepatic dysfunction in the form of elevation of liver enzymes. So your transaminases, aspartate and alanine transaminases, their levels can rise. Does not cause any hepatic impairment as such, but the enzyme levels are elevated, right? Teratogenicity, there are teratogenic effects with carbamazepine, but they are relatively lesser compared to a drug like phenytoin. So you could have fingernail hypoplasia, craniofacial defects, delayed fetal development. These are all possible. So would you use carbamazepine in pregnancy? Even though the chances of teratogenic effects are lesser than phenytoin? No, carbamazepine is also not used for pregnancy. You have, and here itself you can also remember that valproate is also not used in pregnancy. Phenytoin and valproate are absolutely contraindicated in pregnancy. Carbamazepine is relatively contraindicated. There may be use, but now the newer drugs like lamotrigine are more used in pregnancy because they tend to have very little teratogenic effect. Okay. Other uses of carbamazepine are important. So carbamazepine is very important for treating neuropathic pain. This is a very troublesome problem. It causes severe pain, persistent pain to the individuals, and the causes of neuropathic pains are linked with trigeminal nerve. So it's called as trigeminal neuralgia, glossopharyngeal nerve, glossopharyngeal neuralgia, and there is also something called as post-herpetic neuralgia, something which happens after a person suffers from herpes infection. Okay. Carbamazepine has also been found useful in treatment of bipolar disorder or manic depressive psychosis. I talked to you about BPD or bipolar disorder. where there are alternating periods of mania and depression. Prodrugs of carbamazepine are now available as separate drug formulations. So there are two drugs which have come out. One is oxcarbazine. It offers the advantage of having less enzyme induction, thereby causing less drug interactions, and also causes fewer hypersensitivity reaction. Then there is another formulation called eslicarbazine, not available in India, exclusively developed, marketed in the US. So these are newer prodrugs of carbamazepine. Now comes probably the most used drug in epilepsy, which is valproate or valproic acid. It comes as a sodium salt like phenytoin. So there is phenytoin sodium. Similarly, you have sodium valproate. There is also valproate semi-sodium, a preparation called as divalproex. What are its mechanisms of action? Everything. Inhibits use-dependent sodium channels, inhibits T-type calcium channels, enhances the action of GABA by inhibiting its metabolism as well as increasing the synthesis, also decreases the release and synthesis of excitatory neurotransmitter, which is glutamate. So all important 4 mechanisms are possible or are there with valproic acid. Use, it is the broadest spectrum anti-epileptic, it's actually the drug of choice for every important epilepsy or seizure type that you can think of. Okay, so it will be the drug of choice for GTCS, for focal or partial seizures, for absence seizures. Where do we avoid it in absence seizures? Young children, very young children, less than 2 years definitely, preferably less than 5 years also. What do we use there? We use ethosuximide. Okay. It is also useful for epileptic syndromes like Lennox-Gastaut syndrome. Again, Lennox-Gastaut is a epilepsy which affects children around 5 to 10 years of age. It can cause multiple seizure types. There is intellectual impairment in the child. So it's called Lennox-Gastaut syndrome. Infantile spasms, hips arrhythmias, first year of life happens. Now, what are the main adverse effects? For valproic acid, GI and CNS adverse effects are the main issues with valproic acid. It can cause gastrointestinal irritation. It can cause CNS depression, just like all other anti-epileptics do, because eventually we are inducing some extent of CNS depression, right? Alopecia, rashes, weight gain have also been known to occur in a subset of patients. So these are the adverse effects. Just like carbamazepine, there is also a problem of elevation of liver enzymes seen with valproic acid. So you have to be careful when you use carbamazepine or valproic acid in individuals who have pre-existing liver impairment, hepatic impairment जिनका already हो रखा है. So you have to monitor those individuals. Pancreatitis is a rare but serious problem which can happen with valproic acid. Food delays the absorption of valproic acid, so it is given after meals because it prevents the GI adverse effects. There is very high plasma protein binding of 95%. Unlike phenytoin and carbamazepine, which are enzyme inducers, valproic acid is an important enzyme inhibitor. It's a microsomal enzyme inhibitor, and particularly CYP2C9, and there is another enzyme called UGT. UGT is also responsible for, so it's uridine glucuronide transferase is also responsible for metabolism of a small group of drugs. So because of that, you see multiple drug interactions. You see valproic acid interacting with phenytoin, phenobarbital, lamotrigine, all important anti-epileptic drugs, also with lorazepam, because lorazepam has some connection with UGT. Valproic acid gets converted into active metabolites. These are the general doses for valproic acid, 300 to 500 milligram twice daily. What else? Yes, with valproic acid also there is a high chance of teratogenicity. It causes NTDs, what we call as neural tube defects. NTDs can manifest as spina bifida. There are non-epileptic uses of valproate. Can you recall any non-epileptic use that you have come across for valproate? Have you read about valproic acid or valproate in any other condition? Can you recall any psychiatric condition? No. Again, yes, bipolar disorder. So, along with carbamazepine, valproic acid is also found to be useful for manic depressive psychosis or bipolar disorder. It's a well established drug for prophylaxis of migraine. Okay. If you go into the autocoid system, if you talk about treatment of migraine, you talk about NSAIDs and triptans. But what about prophylaxis of migraine? Can you recall some drugs which are useful for prophylaxis of migraine? One is valproic acid. What are the other drugs for prophylaxis of migraine? Propranolol, which is a beta blocker. Then calcium channel blockers can be used. Then other than valproate, another anti-epileptic drug which is approved and well established for migraine prophylaxis is topiramate. Topiramate. Okay. Can be used for trigeminal neuralgia also, has found use for Cushing syndrome, tardive dyskinesia. Coming to the fourth major group, drug, ethosuximide belongs to the class of succinimides. What is its mechanism of action? You know by now. It's a pure absence seizure drug. Only one mechanism of action. Inhibits T-type calcium channels. Okay. So, these are the thalamocortical current carrying channels. Use, again, only one use, absence season, and particularly which age group? Less than 2 years, less than 5 years. You can consider both age groups. Alright. Main adverse effect does not have very characteristic adverse effects. Again, GI and CNS adverse effects are mainly seen. Just like valproic acid, gastrointestinal and CNS depressant adverse effects are seen. In some people, in children as well as in adults, behavioral disturbances, problems like agitation, aggressiveness, restlessness, these kind of problems have been seen. The most serious adverse effect seen very rarely, but it has been documented, is bone marrow suppression or bone marrow depression with ethosuximide. Even deaths have been reported due to bone marrow depression. It's very rare, happens in less than 0.1% of patients, but it has been documented. Okay? So, that's all about ethosuximide. The pharmacokinetics, there is no significant plasma protein binding. I hope you all know what is PPB now. It's plasma protein binding. It gets metabolized in liver, but there is less role of CYP enzymes. So, that is why in the previous drugs you did not see ethosuximide as part of drug interactions, because it has very little metabolism through CYPs. It also has lesser teratogenicity. So, when absence seizures may be there in pregnancy, this is the preferred drug. But it is quite rare to see absence seizures in pregnancy. Why? Because absence seizures are characteristically seen in which age group? In children, right? Okay. A word about benzodiazepines. You all know about benzodiazepines. So, where do they fit in for anti-seizure or anti-epileptic drug therapy? They are known to have good anti-seizure effect. The main problem is that there is a significant degree of drowsiness and sedation associated with benzodiazepines, and you also see tolerance which develops over use, chronic use. Multiple drugs are known to be effective in epilepsy. Let's recall them: lorazepam, it's not pan, it's PAM; diazepam, clonazepam, it's, I don't know how the spellings are a bit off; clobazam. So, they all have the same mechanism. What is the mechanism? Acting on the modulatory site on the which receptor complex? GABA, benzodiazepine, chloride, ion channel receptor complex. Okay. So, they increase the frequency of opening of these chloride channels, and thereby they have a GABA, which type of effect? Facilitatory or mimetic? It's a GABA facilitatory effect. And what do barbiturates have? They have both GABA mimetic and facilitatory effects. Alright. Clinical uses, Lorazepam is very important for status epilepticus. It's the drug of choice, the first drug to be administered IV for status epilepticus. The alternative is giving intravenous diazepam. All right? Diazepam, other than status epilepticus, it's also very important for febrile seizures in children. And the route of administration, you may have read this in your general pharmacology. Rectal route of administration, the example is rectal diazepam in children for febrile seizures. Okay? Then clonazepam, it is effective in absence seizures. Clobazam is less sedative, longer acting, so maybe a little more use as an add-on drug for seizures. So these are the 4 benzodiazepines. Now newer drugs, I will finish off here. I will just introduce the names of the newer drugs. In the class on Monday, the next Monday, we have a 2 to 3 class, that is where we will take up all the new drugs. We can further classify them into 2nd generation, 3rd generation, and we will also look at general principles of using anti-epileptic drug. So I expect you guys to read up and come. That's a task for you. So what are the new drugs? And I am here putting up the 2nd generation drugs, which are more in clinical use. So have a look at the names of these drugs, starting with lamotrigine, felbamate, topiramate, levetiracetam, zonisamide, tiagabin, gabapentin, pregabalin. If you have looked at previous slides a bit closely, you will be able to tell me mechanisms of some of these drugs right here itself. What about lamotrigine? Like valproate, has almost all mechanisms of action. Felbamate, it is a glutamate blocking drug through NMDA receptor. Topiramate, similar to lamotrigine, it has multiple mechanisms of actions, broad spectrum. Levetiracetam, ये हमने पढ़ा था. Yes, synaptic vesicle protein inhibits the release of which? Glutamate, and increases the release of GABA. Zonisamide, sodium channel plus a couple of other mechanisms not very well understood. Tiagabin, ये हमने पढ़ा है, inhibits the reuptake of GABA through what? GABA uptake transporter, GAT. Gabapentin and pregabalin, related to GABA again, can cause increased synthesis or release. Did we see gabapentin and pregabalin somewhere else also? Yes. The N-type calcium channels are where these drugs also act upon, thereby acting on glutamate release, decreasing glutamate release. So although primarily they were developed as GABA acting drugs, they have also been found to have effect on glutamatergic neurotransmission. Last thing, gabapentin and pregabalin, you will find them written very commonly to diabetic patients. Can you think why? Diabetic neuropathy. These are also drugs which are very helpful in neuropathic pain. Both gabapentin and pregabalin are effective in neuropathic pain, and they are given to diabetic patients who develop painful neuropathy. Okay, so with that we finish this class. Any questions? Any doubts? All right, please take the attendance.